now we can start the session.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have Dr. Arvind Prasad Gupta, sir, who is teaching us about the critical thinking while doing the arthroscopy and what errors we can avoid. So over to you, sir.
Thank you, Janki. So today topic is think before you spoke. So critical error in orthoscopy. Though orthoscopy has evolved a lot in recent 10 years, but still there is a lot of error happening before surgery, during surgery, and after surgery regarding to the orthoscopy and post injury. So it's a very vast topic, but I'll try to cover as much as possible in the time which is given to me. So basically, my talk will highlight the critical importance of careful planning and execution of orthoscopy to basically avoid the iatrogenic injury. At the same time, this will ensure the maximum output to the patient. So it's a start with the pre-op planning and assessment. And we all know that in pre-op planning, mostly the history, physical examination, and investigation comes. So let's see this patient. So this patient was referred to me as a multi-ligament knee injury, and patient was advised for surgery, and patient comes with full preparation to me with MRI, everything. Doctor, I want to get surgery done. But if you see very careful the knee, so this is the part which looks healed, but this part still don't look full healing of this part. So basically in the physical examination, you have to look for the things which can create problem intraoperatively or postoperatively. So that things comes into the planning. So this patient was delayed from surgery point of view. So next, this was the X-ray. This patient comes to me in 2017 only with this X-ray. That doctor, I got fracture and need to get fixed. So by seeing this, Janki, if you see this, it looks like something fracture in the fibular head, as well as this is the part. This is the part of the fibular head, and this is the part which has comes from here. So this is the fibular head, and this is the part of Guddy tubercle. So seeing this at the same time opening on the lateral side, it just note the fracture things that is happening in the knee. So something else has also involved. So this again comes to the planning, which investigation we should ask after seeing such type of X-ray. You should not going to just fix the fracture. Now your job done, and patient will be happily after 2 months, 3 months. This patient will come back to you again. So initially this was planned by some other surgeon that I'm going to fix this fracture and you will be fine. But no, there was something associated with that, and this get confirmed with the help of MRI. So whenever there is chance for getting investigation like CT, MRI to confirm your diagnosis, always do that. Your planning, your treatment will be 100% sure when your diagnosis is 100% confirmed. So you can see here, there is injury to the ACL also. So it was not the fracture of only fibular head. There was avulsion of the Guddy's tubercle from here. Fibular head avulsion, Guddy's tubercle avulsion, as well as ACL injury was also there. So if you see the anatomy here, so this is the Guddy's tubercle that was fractured. This is the fibular head that was fractured. And at the same time, there was ACL tear. So along with the fixation of the fibular head, as well as the Guddy's tubercle, the ACL reconstruction was done at the same time. You can explain to the patient about the reconstruction of ACL in second stage also. There is no harm in that. But if you have ability to do all the things in the single setting, you can go with that. So, and after this, if you are doing the acute ACL reconstruction, the chances of a stiffness become high. So be careful. This is just after this X-ray, just after 4-5 months. 5 or 6 months, you can see here. The fracture has fully united and he has full range of motion. You can see the scar here. So it's just not only the surgical part. You have to think about the post-op period. You have treated the Gudis tubercle fixation. You have fixed the fibular head. You have reconstructed the ACL. So very high chances of stiffness considering all was done in acute setting. So think after surgery also. So do according to your physio planning according to that only, so that patient will have full range of motion. And after this history examination and investigation, identify the potential risk. As I discussed one thing about the open wound, anything around the knee, or any diabetic, any chronic illness that may increase the risk of infection with your surgery. So always identify this. And also other things related to trauma, like this was the patient, this is just 20-year male boy, the knee was dislocated, that was immediately reduced. Okay, Janki? Hello?
Yes, sir.
So Janki, this was the
Yes, sir.
x-ray that was immediately reduced. Okay, so what do you think, your job done or you need anything else?
No, sir. We actually, after the reduction, if we'll see if for the angiography, if it is doubtful vascularity
Perfect. So
and
your
MRI
so
is,
your
yeah.
definitely, so your approach is good. So just you, if you see this, this is the posterior dislocation, okay, and this was reduced. After reduction, it was done at a very high volume center, and patient was referred to the home. But if you see this posterior type of dislocation, very high chances of injury to the popliteal artery. The same thing happened here also. Patient was sent to the home that your knee has reduced. You come after 4 weeks for anything extra if I have to do about the ligament surgery. But if you see, this is the condition of the limb of that patient. Patient developed the compartment syndrome, blackening of the foot, for which the compartment release was done. And if you see the CT angio, this patient was having injury to the popliteal artery. So such type of orientation always you should have. Anything posteriorly, like posterior dislocation or posterolateral dislocation, very high chances of injury to the popliteal artery or your peroneal nerve. So in such type of cases, after reduction, you should always look for distal pulses. That is very important. And in case of any dot, always go for ankle brachial index. That is again very important. And if it is less than 9, immediately go for angiography to look for any vascular injury or not. Many a time, such type of patient develop intimal damage. That leads to the slowly development of thrombosis into the popliteal artery. And that leads to development of ischemia after 7-8 days. Like in that case, that patient developed after 7 days of blackening and compartment syndrome. So in such type of cases, you have to go for serial documentation of ankle brachial index. Okay, so just reduction is not going to complete your job. So all these things you have to consider. So in examination, don't focus only to the knee. You have to focus to distal pulses, about the vascularity, about the neural injury, any type of dislocation on the knee joint. So identity, and at the same time, understanding of anatomy is also very important. So if you see on the medial side of the knee, you will have medial epicondyle, adductor tubercle, gastrocnemius tubercle, and also the insertion of ligament. All these ligament insertion has to be in your mind. If anything difficulty during the intra-op, you can paste your picture over the wall there and you can identify. So if you see on the medial side, there is MCL insertion that is almost posterior and proximal to the medial epicondyle, and nearby to that there is tunnel for your PCL also, particularly for the multi-ligament type of thing. So you can see here, this is the medial collateral ligament insertion and this is the tunnel for PCL. Similarly, on the lateral side, the anterior is the fibular collateral ligament and the posterior is the ACL along the blue state line. So just considering this anatomy, I'm coming to this one of my case. This patient came to me in 2015 only with severe instability around the knee. Varus test was positive, dial test was positive, anterior was positive. And this patient was operated multiple times in different city of the India. So if you see here, this was looks like something done on the lateral collateral. This was for the ACL, and this was for the osteotomy. But in the lateral view, if you see, so this lateral collateral insertion is almost anterior to the femur. Ideally, it should be there. This is for the ACL, it should be there at least, ideally. So this anatomical identification has to be very important. So if you see the CT, this get confirmed. Instead of here, this is there, and 2 times ACL was done. You can see the 2 screw in the femur. So 2 times ACL with posterolateral corner with osteotomy in the tibia for multi-ligament knee injury of this patient. So this was the CT. You can see the tibial tunnel also. So revision was done. Bilateral peroneus longus was used in 2015 for 3rd time ACL reconstruction as well as the posterolateral reconstruction also. So now you can see the lateral epicondyle isometry point is exactly at the anatomy. The ACL point is here. So it is no longer vertical tunnel is here. So identification of anatomical landmark is very important at the time of doing surgery. Next is the meticulous surgical technique. So in meticulous surgical, you have to avoiding blind introduction of instrument. Like just making the first anterolateral portal, we usually put the trocar. Trocar should go very guided. Like in this case, if you see, there was little bit trocar invagination into the PCL here, because PCL is just in front of your trocar in the intercondylar area from anterolateral side to anteromedial side. If you go toward that, the PCL will come in front of you here, and that may get sometime invaginated with your trocar. So next is the positioning. Most of the time we do in supine position with tunicate on. So in the tunicate, you always put the proper padding here. And also you always check the movement of your knee, particularly during the figure of 4 for lateral compartment job, full flexion for your ACL. So you can do it in leg hanging position also. You can do it in foot over the table also. So all these has to be checked pre-operatively before putting the scope, that everything is you can do all the movement of the knee over the table. And then before putting the portal incision, you must do all these landmark marking, particularly for the initial days, because many a time your surgery goes longer duration and knee becomes swollen, and the identification of anatomical landmark become very difficult. So first mark the patella, followed by the tibial tuberosity, then you mark the patellar tendon here. So you can see the patellar tendon get marked, and then after that you start marking your portal. First the anterolateral portal, that is 1 centimeter below the joint line. So you can see here, so this is the soft point here, that is the joint line. On the lateral side, similarly joint line. On the medial side, okay? And then you make all these portals starting from anterolateral, anteromedial, superolateral, superomedial, then the posteromedial portal. So this landmark is very important before you before you have started the surgery, particularly if you are a beginner and you have just started doing your arthroscopy cases. Then the proper visualization is very important when you put your scope inside the knee joint. That will prevent the arthrogenic injury. Like after making the anterolateral portal, you do make the anteromedial portal. That is your working portal here with the help of knife. So you can see after putting the knife here, you must visualize inside also your knife like this. You can see here. So you just first pass your needle. So this video is sorry, this video. So you must visualize from the intra-articular side, that there should not any injury to the meniscus or medial femoral condyle, because at the time of putting the knife, very high chances of injury to the meniscus as well as the medial femoral condyle. That you should always look from inside where your knife is going, okay? And also this visualization is very important for making portal on the posteromedial side. So first make your landmark here, then you put your knife and needle, and then followed by your knife. Like here, you can just see how you pass your scope into the posteromedial gutter in between the PCL and the medial femoral condyle. And once it is on the capsular side, then you start passing your. Then you see here under vision, you are putting your knife. You can see first pass the needle, followed by under vision you should be passing. In this way, the proper visualization is very important inside the knee joint. In this way, you will prevent any iatrogenic type of injury. So this is how this looks. So this is the needle. This is a other side, another knee. You can see needle has been passed over that. You can see this type of lesion, that is the ramp lesion is there, and you can do the repair in a very good way once your vision is very clear. And third things comes the gentle manipulation. Like this case, this was a case of medial meniscus injury. Here you can appreciate this medial meniscus injury. It is a complex type of injury. And if you see the joint on the medial side, most of the time it's very tight. And you can see tear here, tear here, tear. And in such a tight joint, the passing the instrument become very difficult. And if you pass without opening the joint, very high chances of injury to the cartilage. So in such type of cases, if you see here, the first pie crusting you should be doing for this. And at the time of doing pie crusting, you should be very careful that you are not damaging the MCL completely. It is just the doing the pie crusting. You can see just it got open and you have to stop here. So you have to stop here and just watch this. You have to stop there. Otherwise, any time there is complete rupture of the MCL happen. And just putting the needle, you can see the meniscus get moved with the needle. And just this is the opening. You have to be very gentle at the time of opening of you. So gentle manipulation either on the medial side or lateral side is very important to prevent any iatrogenic type of injury. At the same time, you should be aware about the anatomical variation, particularly if you are doing the PCL type of PCL reconstruction or any work in the posterior compartment, because the popliteal artery is very close, and all these variation may be in your patient and may get popliteal artery may get damaged, and this will lead to disasters. And also about the nerve, this infrapatellar branch of the saphenous nerve that is very close to your hamstring tendon, and many a time this get damaged. If you can prevent injury to this is will be one of the best thing. At the same time, the common peroneal nerve come very close on the lateral side. So doing any meniscus walk here or lateral collateral ligaments type of surgery, be very careful about the common peroneal nerve injury. At the same time, the fluid extravasation management is also very important, particularly if you are doing work on the posterior side or doing orthoscopy in acute setting, because in the calf, many a time the fluid invasion extravasated, that may lead to compartment syndrome. So this is the shoulder joint. You can see how much swelling this get, and this I got from the literatures. You can see the lot of swelling in the neck, face, and this patient was kept on ventilator for very long time because of the only fluid extravasation. And the last point is the importance of the experience and the training, that is mastery of the basic technique, at the same time the continuous education. With all these, I'm inviting you all for 8th Bihar Knee Orthoscopy course that is planned on 10th and 11th May. That is Saturday at Lemon Tree House and Premier, Patna. Thank you.
Thank you, sir. While we are waiting for questions, sir, just one thing, sir, about the compartment syndrome. So after the arthroscopy, what and during it, what precaution we should take so that there is less chance of.
So, most of the time, this develop in acute setting. You are doing orthoscopy in acute because your capsule from the joint is torn, and there is very high chances of extravasation of the fluid from joint to the calf. So, if you are doing in acute setting, be very careful. You don't use any type of pump. At the same time, your duration of surgery should not be very longer.
And sir, if it gets developed, then is it the same way what we are doing for the compartment syndrome?
Yeah, yeah,
As you
it's the
told me,
same year get developed. It's the same year you have to do immediate compartment release. There is no other way.
because sir, recently, I think in the last year, we got a referred case from other hospital that's having no movement of the limb after the arthroscopy. He referred here after 3 days. So that patient was how to manage after that, like in the after
So
the
at
three
the end
days,
of
what
it,
is
you have to look for whether it's the full-blown compartment syndrome with the involvement of the sensory and all these, the what is the condition of the muscle. So according to that, you have to take the decision regarding that. Okay. So if it is full-blown compartment for last 3 days, then it's become very difficult for the salvage of the limb. Many a time, it's not the complete compartment; it's impending compartment type of thing that the slow-growing first pressure is there. And if you think that sensory is intact, do immediate compartment release. Look for the status of the muscle, whether twitching, color, consistency, and all this.
it's about the like when we are going for arthroscopy, like in ACL, what are the pre-operative planning in what case you avoid operating and means the contraindications. And other thing is that in pre-operative planning, what all we should see before planning it.
Always look for any external wound, whether around the knee, whether it is there or not. The acute setting, usually if it is lot of swelling is there, patient is in very pain, there is lot of tenderness around the knee joint. Usually I avoid in such type of cases by doing acute surgery. At the same time, if anything about the diabetic side, if HbA1c is more than 8, again I'll avoid doing this surgery.
So, and sir, for a sports person, like in usually we say that MRI to be avoided for few days so that it will be clear to see, to visualize the injury. So in
So
sports
it,
person, sir, how early we can do MRI and surgeries?
so Janki, is not about the timing; it's about the status of the knee. Many a time, simple ACL injury, hardly any swelling. Patient is having full range of motion. There is no swelling. You can go for MRI on day one only. Okay, and many a time there is lot of swelling inside the knee joint. Even at the end of 5 days, you will have lot of edema, lot of hyperintensity in the ligament. So it's about the condition of the knee, it's not about the timing. So if there is swelling, a lot of swelling, lot of hemorrhages, a lot of edema inside the knee joint, then usually I will avoid for a couple of days, maybe a week before going for MRI. Because it's not an emergency surgery. If you think it's the lock bucket tendon type of thing, or root menisc, root tear is there, or such type of thing is there, then definitely you can ask for the MRI. Many a time, almost accuracy is very high for these MRI, even with the edema and other thing. This will help you a lot. But if you ask about the common things, then definitely if there is swelling, edema, hemorrhages, you should avoid asking for the MRI because MRI in acute setting may not be many times required.
And so I've seen in few instances during operation you change your plan for the operation. Like sometimes you just after the uh, diagnostic arthroscopy keep it for some other day, or sometimes you change your plan that you found something else. So how you
That is
during the intraoperative, how to take the decisions, what to do?
that is very good question, Janki. So many a time, if you go inside, there is synovitis type of thing is there, or any low grade type of infection is there. Because even in still in our country, even for the knee pain, patient get injected with the Kenacort, even with the ACL injury for the relief of the pain and instability, and patient develop low grade infection. So yeah, yes, till now, a couple of time I have to delay the surgery because of low-grade infection or synovitis or something else is happening inside the knee joint along with the ACL injury or PCL injury type of thing. So any synovitis, any infection and all these you should be avoiding doing the surgery.
So one question Prasanjit is asking that what is the minimum gap between acute trauma and ACL reconstruction?
So again, it's depend upon the knee condition. If there is no swelling, range is good 90, 100 degree. Usually I advocate for the early surgery, because if you delay the surgery, high chances of your quadriceps is getting atrophy. If associated root meniscus injury, that will get missed. So if there is no swelling, not much swelling, range of motion is good, knee is non-tender, then I straight go for the surgery. But definitely, if there is hemarthrosis, tender knee, swelling, I usually avoid till everything gets settled down. Yes, this duration may be 7 days, maybe 14 days, maybe 3 weeks type of thing. But definitely, threshold for doing surgery, particularly in a young adult population, is low for me.
So one thing, sir, that is that age is a criteria for ACL reconstruction. Like a few days back, I got a patient 57-year-old, although knee was looking quite okay, no osteoarthritis. In that case, sir, is it good to go for ACL reconstruction, or what is the upper age limit where you can say that we should not do the ACL reconstruction?
So 57 is still young, more than 60 is taken as the geriatric. So again, it's depend upon the patient function, how unstable knee. Same ACL tear, you may have grade 1 anterior door, same ACL tear, you may have grade 3 anterior door test. So it's also depend upon the laxity of the knee joint and how much symptom patient is having. If patient is very symptomatic, knee is very frankly unstable, this pivot shift is grade 3 pivot shift is positive, any twisting injury, repetitively twisting injury, usually patient needs surgery. And those who are sedentary, office worker, there is not much anterior door instability or rotatory instability, you can conserve such type of patient. Even you can conserve young patient also if there is no much laxity inside the knee joint.
So, sir, is that the indication for conservative treatment of ACL, if we can say that if it is younger patient, sir, there is chance that after the ACL injury, the meniscus and all will also get degenerated with the age. So
Yeah.
that is one school of thought, sir. So what is your like how to describe the patient that in your case it is needed that you forgo for surgery or otherwise to conserve?
Most
And
of
if
the
we are
time,
doing the conservative treatments, and what are the thing we should explain? Like,
again, I say
uh, yeah.
knee should not be very unstable if you are planning for conservative, irrespective of the age. Because unstable knee, any age group patient will not tolerate. Patient will have this pivoting type of repetitive twisting type of injury on walking irregular surface, climbing a stair, everything. So any unstable knee, irrespective of the age, patient will not tolerate. Okay. So if knee is stable, then you can ask for go for conservative treatment. And at the same time, patient has to be doing lot of exercises. They has to build their muscle and tendon around the knee joint.
So in that case, sir, static quadriceps and hamstring is strengthening.
It's hamstring, all hamstring, quadriceps, everything.
Okay, sir. Okay, sir. So think.
Sir, one doubt, sir. I have
Yes,
Yeah,
yes,
sir.
Raja.
Raju.
Sir, although sir, you have told this earlier, sir. Sir, in multi-ligament injury, sir, the sequence of corrections or the sequence of reconstruction, sir.
So, very good question. So, in multi-ligament reconstruction, if you see the fixation points, you make all the drill for the ACL, PCL, posterolateral corner. You first interarticular part, the tunnel making, and then you pass graft on the PCL femur. Then you pass graft on the ACL femur. Okay, and then on
Yes.
the tibia, you first fix the PCL because PCL is your central stabilizer. So this is your knee, this is your PCL. So this is your central stabilizer. Once you fix this in this position, your knee get settle and stable and reduce.
Sir, just lift it up, sir. Will not.
Okay?
Yes.
So this is your PCL. Suppose this get torn. This your tibia move like this. Once you pull, reduce it and fix the PCL, your knee get reduced. So this is the central stabilizer. And after that, you come to the posterolateral side because this is the laxity is because of your posterolateral side. You fix the posterolateral side, then you come to the ACL tibia. You fix the ACL tibia here, then you comes to the medial side, that is the MCL.
Sir, in one sir, that article that they have told like acute reconstruction and sir and in that they have told in acute reconstruction we can the सर जैसे अभी आपने बताया and then in one type they have told that we treat the MCL and LCL and then we after 6 weeks we go for ACL and PCL.
So definitely you can go with the two stage, but if you are doing for the single stage, then this was the sequence. But if you are planning for the two stage, then you first do the collaterals, then followed by the intra-articular.
Yes, sir. First collateral, sir. If you are planning for to say two.
Extra-articular, most of the time extra-articular first, then followed by the intra-articular.
Oh, thank you.
Thank you.
Yes. I think if anyone have any other doubt, you can ask right now. Otherwise, we'll. Okay, sir. Thank you very much, sir. And
Thank
I
you,
think,
Janki. Thank you very
yeah,
much.
yeah. Thank you. Thank you very much, sir.
Thank you, sir.